So, foundation of critical care nursing. This is the part 2. Psychosocial and spiritual consideration. What are the common traits for patient in critical care unit? First of all, they said pain, discomfort, and physical restriction. Unfamiliar environment with excessive light, noise, alarm, or distressing events, loss of ability to express oneself verbally with the introverted, unfamiliar bodily sensation resulting from bed rest, medication, any kind of surgical operation, or any symptom. Also, threat of death or lack of sleep. So when a person is diseased or any kind of sickness, so they think they're going to die. And fear and anxiety work because nobody wants to die. So sickness actually a threat of death, right? A new symptom, loss of autonomy and control over one's body, environment, privacy, and daily activities. What else? What are the other common traits for patients in critical care unit? Continue. So any kind of like broken only by brief visit, threatening stimuli, and also procedural touch, separation from family, friends, and meaningful social rules and work. So like a baby, what is the baby's anxiety? Baby's anxiety if they separate from the parents. Also, family sometimes broken, divorce, right? So it is a separation from family or friends. And it is actually sometimes everybody's coping mechanism is not same. Loss of dignity or feeling embrace and exposure or sense of vulnerabilities. Also worry about the finance, potential job loss, stress on loved one, uncertainty about the future and fear of permanent residual health deficit. Also unanswered spiritual questions and concern about the meaning of events and life. What else? What are the individual response to the stressor and depends on individual perception of stressor, acute or chronic nature of stressor. Also, cumulative effect of multiple stressor. So individual perception of stressor. So if everybody's capability is not same. What is easy to you, maybe not to me. Or what is easy to me, maybe it is hard for you. And definitely as a healthcare provider, as a doctor, we always have to find out what is the underlying cause of my patient anxiety or stress. What are the medical cause of stress? I'm not talking about the psychological factor only or any kind of psychiatric disorder. There are some medical conditions can lead to anxiety or depression or stress, including like if anybody's thyroid is imbalanced, can possible to anxiety or depressed. So we need to check thyroid stimulating hormone, free T3 and T4. We have to check blood hemoglobin level because When hemoglobin go down, patient can feel depressed or anxiety. Also, it is important to check the other laboratories like vitamin D. Okay. So in a short, I want to tell you what are the pathological cause need to evaluate, and we have to check laboratory test, particularly vitamin D3 or TSS, thyroid stimulating hormone, T3, T4, and hemoglobin. So next, say, also we evaluate, is it acute or chronic? So if it is one episode, or if same episode come and again, or continue more than 3 months, we call chronic. Cumulative effect of multiple stressor sometime, right? Effectiveness of individual usual coping strategy and style. Also, degree of the social support need to, because sometimes some client do not have enough social support or family support, so we have to evaluate it too. So psychosocial and spiritual consideration, the body's neurohormonal response to stress include initial events, compensatory phase or progressive phase, and also refractory phases, or help us understand the physiologic events happening during the critical illness or injuries. So our body is feels sick or mentally imbalanced or any stress when occur, the hormone imbalance is most common, right? So body neurohormonal response to stress, we need to evaluate too. Coping mechanisms are useful also. What are the coping mechanisms? So two common coping mechanisms that are often used to access in critical care environment are regression and deny. What is regression? So it is reverting to a less independent state. And what is denied? It is pathological avoidance of a real problem, right? This is several categories of deny. Anxiety can be observed behaviorally or elicited verbally or measured with a standardized assessment tools. Critical care environment may result in the self-concept disturbance of disturbed body image, low self-esteem, also personal identity disturbance. So you see, self-concept disturbance of disturbed body image. So everybody's body image is not bad, that they feel disturbance for this. But I said, when any person is broken, less confident, they thought, I am not good enough, good look, so he or she reject me. So they make a clue. But you know, when we do not need to the how I look like, it is important how I do, what is my abilities, how I'm thinking, how can use my brain, right? So, but the people who is broken or who is depressed or anxiety, they have a low self-esteem. They feel they're nothing. Or personality identity disturbance, these psychological issues. Also, compromising dignities, feeling powerlessness because they are depends to others, a spiritual disturbance, hopelessness or nursing management. So also hopelessness, right? So all of this, like feeling powerlessness, spiritual distress, hopelessness, and nursing management issues common to critical care setting. So although physiological care is essential to life, psychosocial intervention are also life sustained by providing and supporting security, trust, dignity, compassions, coping, and self-control, and also spirituality. So what are the environmental support by critical care nurses? And is aimed at reduce the noise and bright light and limited the nighttime disruptions. So it is good to give them quiet environment. Use of natural light or smooth, very relaxing music, smoothing music. Familiar items such as photography may increase the patient's orientations and feeling of well-being. Comorbid psychiatric disorder. Example, suicide ideations or suicidalities may result in critical care stay, or addressing this disorder and their potential side effect, that is alcohol withdrawal. So alcohol withdrawal symptom we need to manage it and is a part of a critical care nursing. Also, what are the post-intensive care syndrome? Occur after the discharge and is characterized by profound weakness, cognitive impairment, and psychiatric impairment. Family member may also be affected. Up to 62 of critical care survivors experience the post-traumatic stress disorder, shortly called PTSD. So something happened very bad with them, but it is hard for them to forget. Post-trauma, major depressive disorder, and anxiety disorder. So self-care for nurses working in critical care setting. So help them avoid burnout and compressions fatigue. Self-care include self-reflection, stress management techniques, and exercise. So if you know how to do the self-reflection or how to control the stress, right? Other stress can eat you. It can bite your brain, leak your heart, and also bad for your memories. Also, how you know how to do the meditation, yoga, or some exercise techniques. Here, one question is called class response. A patient admitted 3 days ago is complaining that snakes are in the corner of his room, and he thinks he is at home in his room, and his heart rate 134 beat per minute, and respiratory rate is 36 beat per minute, and he is diaphoretic with a tremor note in the both arms. And which intervention should the nurse do first? So what are the key points in this question? Patient admitted 3 days ago, okay? And admitted because of some complaint. What is this complaint? He thinks he is at home and in his room, and snakes are in the corner of his room, right? It's some visual hallucination. His heart rate 134 beat per minute. So it is a little bit more than normal, not a little bit more, it is actually 2 more. Respiratory rate is 36. Oh, it is also so high, right? Respiratory rate. And he is diaphoretic, means sweating occur because of anxiety, stress, tremor noted the both arms. So which intervention should the nurse do first? Number one, restrain the patients with a soft uh, wrist restraint. Hmm? Administer an order dose of lorazepam. So lorazepam is tranquilizer or anti-anxiety medication, lorazepam, diazepam. But here we are nurses, right? Should we give the lorazepam? Restrained patient with a soft restraint, but we are nurse. We can do it if patient is harmful to me or harmful to other client or other patient. Also, we need doctor order. We need reason why, the type, witness. Number three, notify the nursing supervisor. And number four, notify family that the patient is confused, right? So out of all, the best answer is number two. So they said, administer an oral dose of lorazepam. So basically, let me see which intervention should the nurse do first. So number two say, admin an oral dose of lorazepam medication. The patient is demonstrating the sign of alcohol withdrawal symptom. Lorazepam is an appropriate treatment, and restraint notifying the supervisor and telling the family would not be the first intervention for this patient. So when we work in a facility, we have to follow the facility protocol, and also we have to follow the national guideline. As I told you, this is the question. I am an RN. I'm not give the medication, right? We know that, but something is important. This patient is psychiatric unit. Definitely this patient, nothing we found in this question, patient is harmful or danger to the others. So number one is not an answer. And also number four is not an answer because family notification to the family member is not a justifiable, or it is not a critical thinking to do in the situation. We should notify to the nursing supervisor, or we can notify to the doctor, right? But what I said, something different. I say maybe the protocol to the agency, they said, okay, if patient has any anxiety or sleep disorder, we can give mild dose of diazepam or lorazepam, because patient will not die because of the mild dose of lorazepam or diazepam. So in that scenarios, we may choose number two. So also go another question. A trauma patient report having the nightmare and also outburst of anger, as well as the feeling uptight all the times following a motor vehicle collision in which the patient, the best friend, was killed. The nurse suspect the patient may experience which psychosocial issue? Hopeless, spiritual distress, loss of control, and post-traumatic stress disorder. So my friend, this, if you read this question, you see report having the nightmare or outburst. Why? Because something is happened in life. It is motor vehicle collision where the best friend was killed. So patient, it is difficult for patient to forget the events, right? So the best answer is post-traumatic stress disorder. The patient is experiencing post-traumatic stress disorder. After an exposure to a traumatic events, people may experience the recall to the distressing events that produce an acute stress response. That nightmare and delusional memories, or during which a trauma is re-experienced or provoke the intense psychological and physiological distress. Cognitively, the stress reaction lead to difficulties concentrating or poor executive functions, impaired decision making. The patient show no evidence of hopelessness, spiritual distress, or loss of control. So answer is post-traumatic stress disorder. Another question here. A patient is cold, also creamy, and also diaphoretic, means anxiety, sweating. And he keeps opening and closing his left fist and rubbing his sternum. So patient is anxiety or trying to coping by his way. When his daughter asks him to go to the emergency department, he states that he just has a little indigestion. What coping mechanism is this patient exhibiting? So take a deep breath and you're rubbing over the sternum or a little bit pressure over the slap over the sternum. It is actually patient do when they have anxiety or depression, right? Usually do. So it is also type of coping mechanism. It is because of suppression, regression, denial, or hope. So what are the coping mechanisms he is trying to do? Answer is the three, right? Deny. So when we diagnose in a bad disease, we said, no, it is not my report. Maybe something wrong. Laboratory do something wrong. So it is difficult for us to accept the result or accept with the situation. I'm very angry with it. It is not my report. But after a few times, I'm trying to coping, accept it. And when after accept it, diagnosis is done, then try to recover from the problem. I deny. And finally, try to recover. So patients with an acute myocardial infarction often blame their chest pain on indigestion in an effort to deny the seriousness of condition. Suppression would be correct if the patient was denying that the pain was occurring. Regression would be correct if the patient was exhibiting behaviors from a lower developmental stage. Hope would be the correct if the patient made a statement such as, I'm going to be just fine. It should be the hope. But this patient denied to go because maybe do not like to diagnose some new disease, either pathological or psychiatric. Now here's some nutrition alteration and management. Nutrition metabolism. So everybody know what is metabolism? It is a procedure or chemical reaction take in the liver where the food particles go through some chemical reaction and produce energy as a ATP. So the major purpose of metabolism of the energy yielding nutrient are produced in energy and formation of preservations of lean body mass. So when we eat the carbohydrate or protein or fat, all food go through our digestive tract and broke down to small molecules, like protein go to amino acid, fat go to the fatty acid and triglyceride, and carbohydrate go to break down to glucose. So amino acid, glucose, fatty acid, triglyceride then go to the TCA cycle and again go through some chemical reaction in the liver and formation energy as a ATP, and our tissue use this energy to survive. So the major purpose of metabolism, energy, right, from food or nutrient. So assessing nutrient status. So nutrition, always we have to evaluate, should be conduct on every patient, and also more thorough nutrition assessment should be completed by a registered dietitian or nutritionist on any patients and to the nutrition at the rates. So now here, nutrition alteration and management continuum. First of all, patients who are the risks of malnutrition. Like adults who experience any of the following, like involuntary loss or gain of a significant amount of weight, more than 10% of usual body weight in 6 months, more than 5% in 1 month, even if the weight achieved by loss or gain is appropriate for height. With a chronic illness or disease, like chronic liver disease, the chance to develop imbalance in the nutrition. Chronic use of a modified diet. So you have to take the balanced diet. Increase metabolic requirements, but you demand increase, supply less. Illness or any kind of surgery that may interfere with the nutrition intake, maybe surgery done in the stomach, total gastrectomy, jejunectomy, or ilectomy. So you have to take the rest, your GI tract. Inadequate nutrient intake for more than 7 days. Regular use of 3 or more medication, or food insecurities. So who take the regularly, like diabetic medication, hypertensive medication, any other chronic disease like rheumatoid arthritis, or any other chronic disease like I said high cholesterol or heart failure disease. So infant and children who experience any of the following, like low birth weight, small for gestation age, weight loss of 10% or more, weight for length or weight for the height less than 5th percentile or more than 95th percentile, increase the metabolic requirements. Impaired ability to ingest or tolerate oral feeding, inadequate weight gain or significant decrease in an individual usual growth percentage, and food insecurities for infant and children, and this food insecurities for adult. What else? Now, patient care management of nutritional support. So question comes here. So why nutrition support is important for patient, or which of the appropriate intervention for nutrition support? So they said, whenever possible, the enteral route is preferred method of feeding because of lower cost, better maintenance of gut integrity, decreased infection, and hospital stay. So you see the keyword enteral route is preferred. But before to go a little bit more, I want to tell you that malnutrition is a common and costly clinically also financially. It is the most common and costly, I'd say, clinical or financially. It left untreated most of the cases in patient with or at the risk of malnutrition. The appropriate use of nutritional support can prevent complication arising or produce other clinical, functional, and financial benefit, and also can be life-saving in some situation. Example, I want to tell which kind of nutrition is appropriate, who need it. Basically, nutrition intervention may include optimizing the patient oral intake or provide the oral nutrition supplement, also administering enteral and parental nutrition. So we are nurses and we can play a key role in implementing this intervention. So oral supplementation may be necessary for the patient who can eat and have the normal digestion and absorption. But the person who have digestive tract is impaired, not functioning, or any kind of major surgical operation, they need total parental nutrition. So early enteral nutrition within the first 24 to 48 hours of critical illness, reduce the septic complication and improve the feeding tolerance in critically ill patients. Or it is essential to check tube placement before feeding and also regularly throughout the course of enteral feedings. Patient care management and nutritional support continue. Oral care is provided during the course of enteral feeding, or aseptic technique should be used with all aseptic of catheter care and TPN, total parental delivery. Patients should be also scanned for refeeding syndrome before initiate nutritional support, right? So when patient need, example, patient needed total parental nutrition, we have to check the blood sugar level. Even after the nutrition, we have to check the blood sugar level, because chance to develop hypoglycemia or hyperglycemia. So now few complication of enteral tube feeding. Complication, contribute factors, how to prevent this complication. Pulmonary aspiration means food go through into the respiratory tract. So we have a two pathway. One is the alimentary pathway, other is the respiratory pathway. If food go to the respiratory pathway, it is called obstruction of the respiratory pathway. Pulmonary aspiration. Sign and symptom include tachycardia, shortness of breath, hypoxia, and infiltration on chest radiography. Very important for our NCLEX board. Contribute factor, feeding tube positioned in esophagus or respiratory tract. Also regurgitation of formula. So feeding tube positioned in esophagus is okay, but if it is go to the respiratory tract, this is not okay. Or if go to the any other alternative pathway, food should come back. Regurgitation of formula. So prevention or how to correction, confirm proper tube placement before admitting any feeding. Check the tube placement at least every 4 to 8 hours during continued feeding. Elevate the head of the bed 30 to 45 degrees during feeding unless contraindicated. What else? Consider giving the feeding into the small bowel rather than the stomach in high-risk patients. What are the medication? It's called metoclopropamide. May improve the gastric emptying and decrease the risk of regurgitation. Evaluate the feeding tolerance every 2 hours initially, then less frequently as consider become stable. Intolerance may be manifested by bloating, abdominal distension and pain, lack of stool and flatus means constipation because GIT obstruction may be diminished or absence the bowel sound might be obstruction. Tense abdomen, abdomen distended is the very prominent sign of obstruction. Increased tympani means the sound increase in the abdomen. Nausea and vomiting, gastric residual volume more than 500 ml. Although a high residual volume in absence of other abnormal findings may not be grounds for stopping the feedings. If tolerance is suspected, abdominal radiography may be obtained. So if you take a simple X-ray or radiography of the abdomen, you can easily find out any kind of obstruction is there or not, or distended gastric bubbles, distended lobe of bowel, or air fluid level. It indicates obstruction. What else? What are the other complication management and risk factor? One is the most common complication, diarrhea. Medication with GI side effect, that is antibiotics, digitalis, laxative, magnesium containing antacid, quinidine, caffeine. So the medication like some of the antibiotics can cause diarrhea, like metronidazole, like amoxicillin, moxiclab, digitalis. It is a medication for heart failure, can cause diarrhea. Some kind of laxatives. If patient has constipation, it can cause diarrhea. Magnesium containing antacid, right, can cause diarrhea. Quinidine, medication we use for malaria or heart problem. Caffeine. So evaluate the patient's medication to determine their potential for causing diarrhea, or consult the pharmacist if necessary. Also, predisposing illness, that is short bowel syndrome. Inflammatory bowel disease is called predisposing illness. Hypertonic formula of medication, like oral suspension of antibiotics, potassium, or other electrolyte, which can cause dumping syndrome, or bacterial contamination formula, food poisoning, like botulinum, or fecal infection with a liquid stool around the infection. So first of all, some medication, we evaluate the patient's medication to determine their potential for causing diarrhea, and also consult the pharmacist if necessary. Use continue feeding, consider a formula with MCT and or soluble fiber. Also, evaluate the formula administration procedure to ensure that the feeding are not being given by bolus infusion. Administer formula continuously or by slow intermittent infusion. Dilute the enteral medication well. Use the clean technique to administering tube feeding. Prepare the formula with sterile water if there are any concern about the safety or water supply, or if the patient is seriously immunocompromised, or keep open contain of formula refrigerated. Also discard them within 24 hours, or discard enteral feeding container, and also administration set every 24 hours. Hang the formula no more than 4 to 8 hours unless it comes the pre-packed in a sterile administration set. So if the cause is the fecal infection, perform digital rectal examination to rule out infection, or see the guideline for prevention of constipation below. Another problem is called constipation. It's a complication if habit, low fiber formula, or creating little fecal bulk, lack of fiber. So it is a factor that is cause. Medication with GI side effect, that is opioid pain medication. Or consider using a fiber contained formula. Ensure fluid intake is adequate. Stool softener may be beneficial. Or ensure fluid intake is adequate, or stool softener may be beneficial. So what else? What are the other complications? Maybe tube occlusion or gastric retention. Let me talk about the tube occlusion first. Medication administered by tube that is physically plugged the tube or coagulate the formula and causing it to clog the tube. Or sedimentation of formula can cause the blocking or occlusion. If medication must be given by tube, avoid use of any kind of crushed tablet, or consulted with the pharmacist to determine whether the medication can be dispensed as a illicit or suspension, or dilution or prevent the osmotic diarrhea, or irrigate the tube with the water before and after administering any medications. Never add any medication to formula unless the two are known to be compatible. So if sedimentation of formula that can cause occlusion, irrigate the tube every 4 to 8 hours during continuous feeding and after every intermittent feeding. If the residual are measured, fluid tube thoroughly before drawing the residual and after returning formula to the stomach before gastric juice left in the tube may cause precipitation of formula, or also instillating the pancreatic enzyme into the tube to remove the prevention of some occlusion. What else? Now, gastric retention. What are the factors? Delay gastric emptying related to head trauma. It is neurological. Any kind of sepsis, infection all over the body. Diabetic or uremic gastroparesis, electrolyte imbalance, or other illness. The cause must be correlated, if possible, or consult with the physician about the use of post-pyloric feeding or prokinetic agents to simulate the gastric emptying. Encourage the patient to lie in a right lateral positions frequently unless contraindicated. What else? Now, nursing management of total parental nutrition complication. So as a healthcare provider, if my patient need to take total parental nutrition or enteral nutrition, and if they develop complication, how we manage it? Like complication, catheter-related sepsis, means infection, or develop the ER embolism. How we manage it? Let me explain one by one. Catheter-related sepsis, particularly infection start, then infection spread to the body through the blood is called sepsis. It's called sepsis, okay, all over the body. And patient present with the fever, chill, glucose intolerance, positive blood culture. If we go for the culture, we can get the bacteria. So use aseptic techniques when dealing the catheter, IV tubing, or total parental nutrition solution. Hang a bag of total parental nutrition no longer than 24 hours, or liquid emulsion no longer than 12 to 24 hours. Use an inline 0.22 micron filter with total parental nutrition to remove microorganisms. Avoid drawing blood, infusing blood or blood product. Piggyback either the IV solution into total parental nutrition intravenous tubing, or they state attaching the nanometers or transducer through the TPN infusion line, or if possible. So anyway, it is actually, if possible, we can use it. If the catheter-related sepsis is suspected, remove the catheter or assist in changing the catheter over a guide wire or administer antibiotic as needed. After the total parenteral nutrition, if patient develop ER embolism, how we manage it or what are the presentation? Patient present with dyspnea, means shortness of breath, cyanosis, lack of oxygen, apnea, tachycardia, hypotension, blood pressure go down, or heart murmur, or also mortality estimate at 50% is depends on quantity of air entering. So if embolism, use the connection, right? LL connection, use an inline air eliminating filter. Have the patient perform a Valsalva maneuver during the tubing change. If the patient is on a ventilator, change the tubing quickly at the end expirations. Maintain the occlusive dressing over the catheter site for at least 2 to 4 hours after removing catheter to prevent the air entry through the catheter tract. So this is important for board exam. The time, the Valsalva maneuver, and dressing. If the air embolism is suspected, place the patient in the left lateral decubitus and Trundleberg position. And also admit oxygen or CPR as needed. Immediately notify physician who may attempt to aspirate air from the heart. If patient develop pneumothorax, means air inside the lungs, patient present with the chest pain, dyspnea, hypoxemia, hypotension, radiographic evidence, and needle aspiration of air from pleural space. Now go thoroughly explain the catheter insertion procedure to the patients, because when a patient move or breathe, or he or she is more likely to sustain pleural damage. Obtain the radiography after incision or insertion the attempt. If pneumothorax is suspected, also assist with a needle aspiration or chest tube insertion if necessary. What else? What are the other complications? Other complications are central venous thrombosis, catheter occlusion or semi-occlusion, hypoglycemia or hyperglycemia. Let me go one by one with some clinical manifestation and nursing intervention. So if central venous thrombosis develop, presentation with the edema of neck, shoulder, and arm on same side as catheter. Also, development of collateral circulation, circulations on chest, pain in insertion site, or drainage to TPN from the insertion site, or positive findings on venography. So follow the pressure to prevent the sepsis. Repeated or traumatic catheterizations are most likely to result in thrombosis. If thrombosis is confirmed, remove the catheter and administer anticoagulant and antibiotics as ordered. If the complication related to catheter occlusion or semi-occlusion, patient present with the no flow or also slowing flow through the catheter. If the infusion is stopped temporarily, flush the catheter with a saline or heparinized saline. So saline solution with heparin. If the catheter appears to be occluded, attempt to aspirate the clot. If this is ineffective, the physician may order a fibrinolytic agent such as streptokinase or TPA, means altiplate, inserted in the catheter. If patient develop most common complication, hypoglycemia or hyperglycemia. In case of hypoglycemia, most common diaphoresis or tremor or shaking, confusion, loss of consciousness. How to prevent infuse TPN within 10% or of ordered rate. Monitor the blood glucose until the stable. If hypoglycemia is present, administer oral carbohydrate. If the patient is unconscious or oral intake is contraindicated, the physicians can order an IV bolus of dextrose. In case of hyperglycemia, most presentation is a thirstiness, headache, lethargy, and increase the urinary output. So how we manage it? Prevention. Admin TPN within 10% of ordered rate, or monitor the blood glucose level at least daily until stable. The patient may require insulin added to TPN if hyperglycemia is persistent. Sudden appearance of hyperglycemia in a patient who was previously tolerating the same glucose load may indicate the onset of sepsis. And what else? So monitor the serum triglyceride at baseline and 6 hours after the liquid infusion, and at least 3 times weekly until the stable. The patient receiving liquid emulsion, reduce the liquid provision in consultation with the registered dietitian. So this is intervention for what? If patient has a hypertriglyceridemia. And how we understand patient have this problem, if we check serum triglyceride concentration should be elevated, especially more than 400 milligram per dl, or serum may appear turbid. How does the nutrition affect the cardiovascular health, or how does the poor nutrition affect the cardiovascular system? We are just going to talk about it here. So nutrition and cardiovascular alteration. So in elderly period after the myocardial infarction, or intervention are aimed at reducing the angina, cardiac outload, and the risks of dysrhythmia, or meal size, caffeine intake, food temperature are monitored closely. So how does the nutrition affect the cardiovascular health? If I ask you, so basically the diet is an important risk factor for cardiac heart disease. The food related the risk factor, including obesity or high blood pressure or uncontrolled diabetes, and a diet high in saturated fat or low saturated fat, high fiber, or high plant food is that can substantially reduce the risk of develop the heart disease, right? Every student know about it. So good food is good. High cholesterol or high fat containing food is not good for heart or can cause the heart diseases. So that basically a diet high in saturated and trans fat causes the cholesterol to build up in your artery or blood vessels. And this put you at the risk for heart attack, stroke, or other major health problem, right? So next, if I read, intervention in the heart failure are designed to reduce the fluid retention, reduce the preload, and calorie-dense food, and supplement provided to patients with a cardiac cachexia. So before to go next, I want to tell you why a balance that is important for cardiac disease patient. Answer should be limiting how much saturated or trans fat you eat is important step to reduce your blood cholesterol and lower your risk of coronary artery disease or cardiac disease. A high blood cholesterol level can lead to buildup of plaque in arteries and called atherosclerosis, which can increase the risk of heart attack or stroke. Let me go next one. So here we are going to talk nutrition and pulmonary alteration. So how does the nutrition affect the respiratory system, or how does the pulmonary disease affect the nutritional status, or can malnutrition can cause pulmonary disease? This is the issue we are going to talk right now. So malnutrition has an adverse effect on respiratory function, decreasing the surfactant production or diaphragmatic mass, vital capacity, and immunocompetence. Because of anorexia, dyspnea, or debilitations or other need of ventilatory support, many patients require enteral tube feeding. So first of all, how does nutrition affect my pulmonary system or respiratory system? So in particular, malnutrition can adversely affect the lung function, and adverse effect of such malnutrition include decrease the ventilatory drive, decrease respiratory muscle function, alteration of lung parenchyma, and depressed lung defense mechanism, right? So how does pulmonary disease affect the nutrition also? Let me explain. So as a result, nutrition depletion in COPD is a multi-faceted also can involve imbalance of energy, like weight loss or protein, and also period of markedly increased inflammation, like pulmonary cancer, which can increase the nutritional losses as well. As a result, the depletion of both fat mass and fat-free mass can occur, right? So if you ask me, malnutrition can cause pulmonary disease. Definitely, malnutrition in COPD may develop insidiously over several years or more accurately as a result of an exacerbation. So it is especially important to alter to the risk of pulmonary aspiration in a patients with a artificial airway, keeping the head elevated 45 degrees during feeding unless contraindicated, and also keeping the cuff of the artificial airway inflected during the feeding. So here I'm going to talk about the how nutrition alter the neurological disease, right? So how does diet affect the neurological disorder? So patient with dysphagia or weakness of swallowing muscular often experience the greatest difficulty in swallow food that are dry or thin liquids such as water, which are difficult to control. Some kind of food beverage may be thickened with a commercial thickening product, infant cereal or yogurt. Fruits may be better tolerated than fruit juices. So first of all, let me tell you. So, I mean, if you ask me, what are the some of the neurological disorder affect the malnutrition, or how diet affect the nutritional disorder? So uh, if food imbalance or nutritional imbalance or imbalanced diet is a part of healthy lifestyle, improve the heart and brain function. So balance or good food, nutrition, balanced food, improve your health, improve your heart, improve your brain function, and reduce the risks of many serious conditions, including stroke, type 2 diabetes, and Alzheimer's disease. So it may also help to manage neurological symptoms. So what are the some neurological disorder induce malnutrition, like stroke, acute or chronic neuromuscular disease, or chronic neurodegenerative disease are the most common neurological disorder linked to the swallow problem and malnutrition. Malnutrition, it present increase the morbidity, length of hospitalizations, and mortality over the course of this disease. So prompt use of nutrition support is important for patients with head injury, because head injury causes marked catabolism, or patients undergo an inflammatory response and may be febrile, increasing the need for protein and calories. So nutrition and renal alteration. So the goal of intervention is to balance adequate calorie, protein, vitamin, and minerals while avoiding excess of proteins, fluid, electrolyte, and other nutrients with a potential toxicities. So Modified diet for the renal patient is important. So patient with acute kidney injury need adequate amount of protein to avoid the catabolism of body tissue, which may further worsen uremia. So when kidney does not work, acute or chronic, both cases, creatinine go up, blood urea nitrogen go up, and patient develop some and symptom we call uremic syndrome or uremia syndrome, uremic syndrome, right? So which with the use of continuous peritoneal dialysis is important. Before to go here, I want to tell you, modified diet for renal disease is important. You may need to make a change to the patient diet when you have chronic kidney disease, or this change may include like limited fluid intake, eating a low protein diet, limited salt, limited potassium or phosphorus, and other electrolyte, or also enough calorie if you are losing the weight. So what use of continuous peritoneal? So if patient kidney doesn't work, we need peritoneal dialysis, hemofiltration, or hemodialysis. The fluid intake can be fluid intake should be monitored, and this allow for more adequate nutrient delivery through the oral, tube, or parenteral feedings. So the need for several water-soluble vitamin, trace minerals, and protein increase in dialysis patient, because the patient who undergo to the dialysis, a lot of protein loss, electrolyte loss, so they need the balanced nutrition diet. Or because these nutrients are small enough to pass through the dialysis filter or dialysis process. So how does the nutrition affect the kidney disease? The basic question. So always remember, your body needs the protein to help the build the muscle or repair the tissue or fight the infection, right? So the patient who have a kidney disease, they need to watch how much protein they need. So we measure it first, then we give them, right? So having too much protein can cause the waste of the buildup in the patient who kidney does not work, or so nutrition and gastrointestinal alteration. So if I ask you, what is nutritional alteration? So nutritional alteration, basically less than the adequate intake or absorption of food or nutrition, right? It is called alteration. So what type of nutrition support will be required in case of gastrointestinal disease? We are going to discuss here. So ascites and edema in a patient with a liver failure have many causes. So if any patient have a liver problem, cirrhosis, carcinoma liver, they have a most common developed ascites and edema. And there is decreased the colloid osmotic pressure in the plasma because of reduced production of albumin and other plasma proteins, increase the portal pressure and causes by obstruction and renal sodium retention from secondary hyperaldosteronism. So numerous therapeutic diets are available for treatment of GI diseases, include highly digestible diet or novel antigen or hypoallergic diet or hydrolytic diet or diet with the added concentrate for dietary fiber. So if patient have any kind of gastrointestinal problem, we choose particular diet, right? So what type of modification diet are recommended for gastrointestinal disease? You have to know. Like the low FODMAP, it is called, that has been associated with improve the symptoms that may there have any patients. So cause of malnutrition in liver failure are complex and related to decreased intake, malabsorption, maldigestion, abnormal nutritional metabolism. So in a patient with a pancreatitis or patient who enteral feeding may be used if delivered the first ligament of trees or which are not stimulate the production of digestive enzyme. What else? So nutrition and surgery. There's some protocol. It is called ERAS. Protocol include the pre-surgical, intraoperative, and post-surgical practice that is involved the entire multidisciplinary team and have lead to a substantial involvement or improvement in recovery time, or reduce the hospital length to stay, and reduce the post-surgical complications. The patients should be allowed to consume a light meal up to 6 hours before surgery and clean liquid up to 2 hours before surgery. An oral maltodextrin beverage should be administered the evening before surgery and 2 to 3 hours before anesthesia. An oral diet can be initiated within the 4 hours of surgery, and patients should be allowed to choose the regular food. So before surgical operation, it is good to instruct your patient what kind of food they should take. And it is also important, any kind of major surgery, patients should be nothing by mouth at least 6 hours before. So now we are going to talk nutrition and endocrine alterations. Here we are going to talk how does nutrition affect our endocrine system, or can the diet causes endocrine disorder? We are going to discuss here. Or also what are the most common cause of endocrine abnormalities that is related to the nutrition. So blood glucose control is especially important in the care of surgical patients. Poor control, a diabetic reduce the immune function by impairing the granulocyte adherence, chemotaxis, and also phagocytosis. Right. So you see the poor control diabetic reduce the immune function. One. How? By impairing granulocyte adherence. This is the process by which the bacteria killed by neutrophil or macrophages. And another procedure called chemotaxis, they secrete some chemical substance and kill the bacteria. Also, the process is called phagocytosis. In this picture, showing some tools that need to measure the blood sugar level. So before to go, next questionnaire is, I want to tell you how does nutrition affect our endocrine system? So adequate nutrition is critical for functioning of all glands in the endocrine system. A protein deficiency impaired gonadal hormone release, or also preventing reproduction, right? So if you ask me, can the diet cause endocrine disorder? So hormonal imbalance can occur as young as age 30 and may be a result of not only aging, but also lifestyle choice, such as poor diet or lack of exercise. The standard American diet is a top contributor of early hormone imbalance. And when hormone imbalance occurs, it leads to the endocrine diseases. So let me go. The next questioner is a patient with a facial trauma is unable to eat after surgery. His albumin level is 1.5. Which nutritional alteration is the patient experiencing? Nitrogen equilibrium. Number 2, negative nitrogen balance. Number 3, positive nitrogen balance. And number 4, nitrogen disequilibrium. So this question, a patient has a facial trauma, unable to eat after surgery. Albumin level is 1.5. Which nutrition alteration? Albumin, we say, is one of the protein. So nitrogen equilibrium lead to negative nitrogen balance, positive nitrogen balance, or nitrogen disequilibrium. So correct answer is number 2, means negative nitrogen balance. Why? Answer is 2. Negative nitrogen balance. Why? The patient has a negative nitrogen balance and is experiencing a high rate of gluconeogenesis, means glucose formation from non-sugar substance. So if you divided this sentence, gluconeo, right? Gluconeogenesis. So glucose formation, non-glucose substance, is a build up his protein source. Muscle mass will break down until nutrition is given. A positive nitrogen balance means the patient is eating more than the excreting. So too much protein intake, positive. No protein, then body produce the glucose from non-glucose substance, like from fat, like from protein. So nitrogen equilibrium occur in normal, healthy adult. So if you are healthy, nitrogen balance should be equilibrium. Nitrogen disequilibrium is a non-exist conditions. So next question, a nurse is providing dietary education for a patient with a hypertension. The patient asks, what are the meaning of DASs? What are the meaning of DASH diet? Which comments is appropriate for the nurse to make? So number 1, DASH refer to the salt-free species you should learn to cook with now. So dietary approach to stop the hypertension. This is called DASs, dietary, A for approach, to stop, S for stop, H for hypertension. So DASH is an eating plan to lower or control high blood pressure. And DASH diet emphasizes the food that are lower in sodium as well as food that are rich in potassium, magnesium, and calcium. Calcium nutrient that help the low blood pressure. And the DASH diet feature menus with a plenty of vegetables, fruits, and low fat dietary product, as well as whole grain, fish, poultry, and nut. So number two, DASH stand for dietary approach to stop hypertension, which comments appropriate for the nuts make, right? And DASH diet eliminate the fruits from the diet. And number four, it means you must eliminate all salt from the diet. So the correct answer is number two, destined for dietary approach to stop hypertension. So dietary approach to stop hypertension is the correct definition for DASH. The object is to consume a diet rich in fruits and vegetables, or potassium and calcium and low in saturated fat to help the control hypertension. So DASH diet does not refer the salt-free species, or one cannot eliminate all DASH from the diet, but lower salt is adversely for those sensitive to increase the salt level. The DASH diet is high in both fruits and vegetables. Second question, a patient has low albumin or pre-albumin and transferrin level with a decrease the total lymphocyte count. Which nursing diagnosis is a priority for this patient? Number one, altered nutrient, more than body requirements. Number two, altered nutrition, less than body requirements. Number three, risks for infection. And number four, fluid volume overload. Correct answer is number two, right? Means altered nutrition, less than body requirements. In this case, the patient is showing sign of malnutrition and protein deficiency that must be corrected. There's a risk for infection, but actual problem is more of priority than potential alone. The patient would have a fluid volume deficit, not an overload. So pain and pain management. Pain, according to the update the definition by International Association for Study of Pain, shortly called IASP. So pain is described as an unpleasant sensory and emotional experiences that associated with or resembling that associated with or actual or potential tissue damage. So physiology of pain. So four processes are involved in nociceptor, like transduction, transmission, perception, and modulation, right? So here we're going to talk about the pain and pain management. So pain management is an accept to medicine and healthcare involving relief of pain in various dimensions, from acute or simple to chronic or challenging. So how does pain management treatment consist of? So pain management approach always include medication, injection, therapy, and exercise. So as a healthcare provider, we may recommend the approach, any one approach like medication, injection, or therapy, or any combination of therapy, or several of them, like exercise and medication, injection and therapy. So pain management plan help to the people with chronic pain feel better and improve the quality of life. So what are the physiology of pain again? The four processes. Now we're going one by one a little bit. Pain and pain management, some physiology of pain. One is called transduction, right? So stimuli and stimulation of nociceptor or receptor or uh, pain sensitive receptor, which called influx, and started the action potential, right? And then they send the reflex to the say fiber, and then transmission is go through the spinal cord, right? Or it is get in the synapse, and then presynaptic or ascending tract of spinal cord, then it go down and brainstem, hypothalamus. It is the pathway of pain or transmission of pain, then hypothalamus, and it's called when it is thalamus or hypothalamus is perception. So limbic system get involved, affected the component, then also partial lobe of cerebral cortex, sensory portion or component, frontal lobe, behavioral component, and also other part of cerebral cortex, cognitive component. And finally, all go to modulations. And this means endogenous opioid production by CNS and spinal cord cell, or link to mu receptor. So mu receptor particularly sensitive to the pain, located to the nociceptor fiber, and also limbic of or substance P production of spinal cord, and also inhibition of pain transmission or analgesic effect. So this is very basic about the physiology of. So in this flow chart, we saw something here. This is called, you see, nociceptor, right? NOC, right? Here. So what is that? Or neurotransmitter particularly. So the physiologically, the pain occurs when the sensory nerve ending we call nociceptor, also referred to as a pain receptor. So comes into contact with the painful or noxious stimuli. This is the stimuli, okay, or pain receptor we call. So particularly this flow chart showing the pathophysiology process of pain, and there are four major processes. I said one is transduction, second one is transmission, and third one showing perception, right? And also modulation. So transduction referred to the process by which the tissue damage and stimuli activate the nerve ending. So if you ask me, what are the different type of pain physiology? Definitely the five most common type of pain. One is acute pain, chronic pain, neuropathic pain, nociceptor pain, and also radicular pain. Let me go next here. What are the integration of potential physiological pain indicator in the biological stress response, right? Biological stress response, right? So first of all, here showing short-term response, release the catecholamine from the brain, and here is showing the effect of catecholamine, right? And here the critical here stress or pain causes hypothalamic effect, antiopituitary secret ACTH, and midterm indirect response endocrine effect, aldosterone secret, corticosteroid secret, and corticosteroid has a multi-system effect, and aldosterone also has effect like increase intravenous volume, decrease diuresis, increase blood pressure, and increase the preload. And also long-term indicate response in immune system or chronic pain get involved too. So if patients have any kind of pain, the basic pain management we should know, right? What about the patient come, the basic management. So before to go basic management, we have to go for pain assessment first. The pain assessment has a two major component. One is a non-observable pain or subjective. Another is the observable or objective pain. So both cases we need management, right, my friend? So analgesic or pain relieving medication or analgesic has a response to control by neurochemical called endorphin, and which are opioid peptides such as opioid, basically morphine, pethidine, so many, meperidine produced by the body. And this substance block the receptor of the pain stimuli by binding of neural receptor that is activate the pain inhibiting neural pathway. So subjective component of pain assessment. The patient has a self-report of pain can also be obtained by questionnaires. The patient using some keyword that can help to remember all of those, and it's called PQRST-UV. So this stand for, you see P stand for here showing all of those. P stand for provocation and palliative or aggravating factors. Q stand for quality, R stand for location or reason, or is it radiate to any part of the body? Like cardiac pain radiate to left shoulder, left jaw, left arm. Pancreatic pain radiate to the back of the midpoint of the back, right? And also S for severity, is it mild, moderate, or severe pain, or other symptom? T for timing, when come, when go. U for understanding, and B for values. So this is the way we can remember, right? So when a patient explains of pain, we have to evaluate by asking some questions. And here showing the pain and pain intensity scale, vertical format. So here the pain scale 0 to 1, right? So here we can see the pain scale, and this pain scale showing 0 to 10. So when it is 0 means no pain, and when it is 10 means worse, pain is worse, right? So in this, if anybody asks you what is the 10 point of pain scale, you can answer the most pain scale are number from 0 to 10. The score 0 means no pain, and 10 means the worst pain or very severe pain, right? And so they said 0, no pain, 1 mild pain, 2 moderate pain, 3 severe pain, 4 very severe pain, and 5 unbearable pain. So this one thing. So there are 4 levels of pain, right? 4 levels. So if pain 0 means pain-free, your patient is pain-free. So 1, it is 1 here. This is pain is very mild, right? And number two, minor pain. Number three, pain is noticeable and distracting. However, you can get used to it and adapt. 4 means moderate pain, and 5 means moderately strong pain, right? And next is, like I said, 6 here, moderately stronger pain that interfere with normal daily activity and difficult to concentrating. 7, number 6 is start severe pain, right? And before 6, it is here moderate pain, right? And number 7, severe pain that is dominate your sense and significant limit your ability to perform the normal daily activities or maintain the social relationship, interfere with sleep. Number 8, intense pain and physical activities severe limit, and also converting require the great effort. Number 9, it is very exacerbating pain, unable to continue or conserve, also crying out or uncontrollable. Number 10, unspeakable pain, right? Possibly delirious, and very few people will have experienced this level of pain. What else? Here talking about some facial expression, behavioral pain scale. Facial expression, upper limbs compliance with ventilations, and also vocalizations. So facial expression usually relax at the very mild case, number 1 scale. Partial tightness, brow lowering, number 2. Fully tightened, eyebrow closed, number 3. Also grimacing, number 4. Upper limbs, no movement, number 2. Partial bend, number 3. Fully bent with a finger flexion, and number 4. Permanently retracted. And showing here compliance with ventilations. Number 1, it is tolerating movement. Number 2, coughing but tolerating ventilations. Number 3, fighting ventilator. And number 4, unable to control ventilation. Now, here vocalizations. 1, no pain vocalization. Number 2, patient start to cry, and less than 3 or not prolonged, less than 3 seconds. Number 2, patient more than 3 minutes or prolonged, less than 3 seconds. Also howling or verbal compliance, including oh wow, right? Breath holding, number 4. Pain and pain management continue. Observable or objective component of pain assessment. So critical care pain observable tools. Here in the picture, we can see facial expression, different facial expression, like 0, relax, natural, tense. Number 1 here, tense, but number 2, grimaces, means all previous facial movement plus eyelid tightly closed with the patient's may present with the mouth open and biting the endotracheal tube. And absence of movement or normal posture protection, okay, about the posture, 0. But number 2, slow and continuous movement, and number 2, pulling tube attempt to sit up, moving the limb, thrusts and not follow comments. It is number 2, restless or agitated. Pain and pain management continue, some indicator, scoring, and some description. Compliance with the ventilations, right? So when tolerating ventilation or movement, coughing, but tolerate tightening ventilations, taking a normal, so it is the numbering showing, also some description you can read. And here vocalizations, sign, muscle tension, and total number out, right? You can read it if you like. Now here, pain and pain management continue, some critical care for pain observing tools. So first one, the patient must be observed at the rest for 1 minute to obtain a baseline value for critical care pain observation tools. Number 1, they set observation for patient at the rest baseline. 2, then patient should be observed during the painful procedure to detect any change in the patient's behavior. And number 2, also observe the patient during painful procedure. Number 3 said patient should be evaluated before and at the peak effect of an analgesic agent to assess whether the treatment was effective in relieving pain. Number 4, the patient should be attributed the highest score observed during the observation period. And number 5, the patient should be attributed a score for each behavior included in CPOT, and muscle tension should be evaluated last, and because it may lead to behavioral reactions for necessarily related to pain, but more to the actual stimulation. According to compliance with the ventilator, the nurse must check the tube as well as the positions and for presence of secretions, which would lead to the high score for these items. Now, pain management continue, pain management guidelines. The patient in critical care routinely experience pain at rest and during the procedure, include regular activities, that is endotracheal suctioning or turning, discrete the procedure, that is tube or drain removal, arterial catheter insertion. Perform a routine pain assessment in all patients. In patients who are able to self-report and their level of pain, use 0 to 10 numerical rating scale, either verbal or visually. So now BPS or BPS in 1 scale 0 to 13, 12, and CPOT scale 0 to 8 are the most valid and reliable behavioral pain scale. So first of all, what are the basic ABCD guide for pain management, right? So there are universal acceptance for ABCD. ABCD means for if patient has a severe pain, we have to check for airway, breathing, and circulation. It is called ABC. And also BSL means basic life support is important. And also we throw the RICE at a spin, means rest, ice, compression, and elevation. So if anybody have a severe pain it as a healthcare provider, we can do for non-medical portion first, like take rest, put ice, compression, and elevation, right? So now, if you ask me, what are the different, what are the three different type of pain management? Basically, we use pain medication, particularly physical therapy, like heat or cold pack, massage therapy, hydrotherapy, and exercise therapy, right? So here, when the patient is unable to self-report, the family can be involved in their loved one pain assessment process if they feel comfortable doing so. Vital signs should use only as a cure for further pain assessment during appropriate and validate methods such as patient self-report report or behavioral scale. An assessment-driven protocol-based stepwise approach for pain and sedation management in critically ill adults is recommended. A multimodal analgesic approach of pain management is encouraged. So, what are the first line of drugs we use for the pain management? Particularly acetaminophen, right? It is analgesic. So acetaminophen usually we use to recommend it as a first line treatment for mild to moderate pain, such as from skin injury, headache, musculoskeletal condition. And acetaminophen is often prescribed to help them manage the osteoarthritis and back pain as well. So analgesic approach to pain management is encouraged, right? So here showing what are the other modalities of pain management. Support analgesic is not enough to manage the pain. So basically in this PowerPoint, we are going to talk what are the, different type of pain, what are the common form of pain management, what are the new treatment for the chronic pain. We will discuss all. So here showing the one transduction process, here is the modulating process, right? So here cell damage release the sensitizing substance. It is called prostaglandin, BK, or 5-HT, right? Or 5P. And now or NSAID decrease the prostaglandins. Action potential reduce from local anesthetics, or many anticonvulsant block the sodium channels. So it is pain receptor, nociceptor, and channel is blocking, and patient has a less pain. Nociceptor and analgesic action showing. So my friend, there are four major types of pain everybody know, like nociceptor pain. Nociceptor means typically the result of tissue injury. And inflammatory pain, another pain, you have to know, this abnormal inflammation causes by the inappropriate response by the body immune system, and patient had a pain. Also neuropathic pain, pain causes by the nerve irritations, and also functional pain, pain without observed origin but can cause the pain, right? So here it's saying some modalities of pain management, maybe something here, nociceptor and analgesic action showing. Picture number 2, transmission of the pain. Okay, this is the one of the nerve ending called spinothalamic transmission. vesicle is come and vesicle is release the neurotransmitter, right? So opioid or medication actually block this substance. Opioid, morphine drugs bind to the mu receptor and block the release of substance P and no more pain. So opioid basically work over there. This is the neurotransmitter, and this neurotransmitter not come this receptor or pain receptor, nociceptor. So opioid is a strong analgesic, but most common use medication can be divided into following category. Basically, one is the NSAID, another, or acetaminophen. These are most common over the counter we can buy. But opioid, always we need prescription. So different type of opioid, different type of NSAID are available in the market. And some of them, like ibuprofen, right? And it is, I said, over the counter. But NSAID also can be effective for acute muscular pain, bone pain, or arthritic pain. But opioid is very effective if pain is very severe, right? So next go, number 3, decrease the perception of pain because of receptor the blocking. Other modalities like spinal receptor, tract neuron transmission inhibitor, opioid receptor inhibit. So neuron from the brainstem release the 5-HT neurotransmitter, norepinephrine, endogenous opioid. Also, some tricyclic antidepressant, TCA, and hence the normal modalities. So this is the different kind of modalities, right? So what are the new treatment of the chronic pain? Basically, is called deep brain stimulation, or shortly called DBT, DBS, also very popular. So deep brain stimulation may offer the alternative to existing treatment. It is already used to treat patients who have epilepsy or movement disorder. And let me go next. So here, the pain management guideline continue. So they said opioid therapy include acetaminophen or ketamine, right? Ketamine is a post-surgical critical care patient we use. And also neuropathic pain medications like gabapentin, carbamazepine, pregabalin. So sometimes if you give gabapentin to the patient, they complain of nightmare, very dangerous dream they have at the night during the sleeping. So they do not tolerate gabapentin. That times doctor prescribe pregabalin for the neuropathic pain management or after cardiovascular surgery. So fibromyalgia pain, right? Most common pain. So we prescribe gabapentin or pregabalin. So what are the most common drugs we use for pain control? Definitely answer is the NSAID, right? So the lowest effective dose of opioid may be used. The procedural pain management and NSAID may be used to discuss for infrequent procedure, chest tube removal. So NSAID basically aspirin compound we use, ibuprofen we use, naproxen sodium we use, or combination of them. So some pain relief contain both acetaminophen and aspirin, right? So multi-drugs. So sometimes we use multiple drugs for the pain management. So because the pain involves multiple mechanisms, to use the combination is especially rational. So also this use to drugs almost always means to combination with the low dose of each. So low combination of drugs is good for pain management. So alternative therapy like massage therapy, music therapy, relaxation techniques, ice therapy are effective, and Also, non-pharmacological intervention for pre-procedural pain, non-procedural pain management is important too. So here one question: the nurse is assessing a patient with a patient control analgesic device who is receiving morphine. The nurse note that the patient has made 20 attempts but has only received 4 doses from the drugs. Which drugs is finding suggest? Select all, apply. Select all. Patient is an addicted. Patient is not using device. Patient require lower dose of morphine in device. Patient need reinforce to educate of the device. Also, patient having unreliable pain. So, correct answer: the patient need reinforcement of education of the device, and patient is having unrelieved pain. So the patient is attempting to administer more dose of the drug that the lockout the period will allow. This could be a sign of unrelieved pain, or the patient could require more education on the device. The patient is pushing the button and so is using the device. If the patient wants more of the drugs than allowed, the higher dose might be necessary. It should not be automatically assumed that the patient is a drug addicted in acute care setting. One more question here. A patient is complaining a chest pain, 9 out of 10 of the pain scale. That has continued for 20 minutes without relief from the rest or of nitroglycerin or GTN. What are the primary nursing diagnoses? Alteration of nutrition, inadequate tissue perfusion, acute pain, or fluid volume deficit. The correct answer is number 2, inadequate tissue perfusion, because this is pain because of analgesia, because of angina, right? Inadequate tissue perfusion is the most life-threatening diagnosis because of potential myocardial infarctions. Acute pain is important and need to deals with the second. Also, alterations of nutrition and fluid volume deficit are important as well, but they are not the primary diagnosis.